Good morning. I'm Dr. Shobhana, second year postgraduate trainee from the Department of Conservative Dentistry and Endodontics of Sri Balaji Dental College in Hospital. I'll be discussing about an article by Noah et al. On quantitative assessment of intracanal regenerative tissues after regenerative endodontic procedures in mature teeth using MRI. According to Rupert, regenerative endodontics is a biologically based procedure designed to replace damaged structures, including dentine and root structures, as well as the cells of the pulp-dentin complex. Regenerative procedure is a common treatment plan for immature necrotic teeth using stem cells of the apical papilla or the scap cells. These cells are found near the root apices and have got regenerative potential. Moreover, immature necrotic teeth have wide open apexes, which allows more stem cells to be recruited to the root canals and thus provide a basis for the success of this treatment modality by Parayani et al. Because of the promising results of the regenerative endodontic procedures in young immature necrotic teeth, they have been recently suggested to treat necrotic mature permanent teeth with apical periodontitis by South et al. There are various challenges faced by regenerative procedure in mature teeth, which are fewer stem cells, narrower apical foramina for induction of blood and stem cell migration, and the last, difficulty in disinfecting the root canal of the mature teeth by Parayani et al. Although the regenerative tissue may not be true pulp tissue, filling the canal with the patient's vital tissue offers following advantages, which are reconstruction of the neurovascular system in the root canal, which will provide an immuno-inflammatory defense mechanism against microbes by Kim et al. There are various options to confirm regenerated vital pulp tissue, which are histologic analysis and X-ray based techniques. Histologic analysis is an invasive procedure and it requires tooth extraction, while X-ray based techniques involve CBCT or CT, and which cannot assess the success of regenerated vital intracanal tissue by Shobhana et al. Hence, MRI being an essential tool for non-invasive diagnosis and monitoring of soft tissue without ionizing radiation can be used to assess regeneration of pulp tissue after transplantation of dental pulp stem cells, both in experimental animal models and in patients by Arigi et al. Thus, the present study aims to address the following questions: whether vital pulp-like tissue can be regenerated in matured tooth after regenerative procedure. Next, does the size of the apical diameter affect the success of regenerative procedures in mature necrotic teeth? And the last, can MRI be used to quantitatively visualize this regenerated tissue in vivo? The study protocol was approved by the Institutional Review Board. Oral and written informed consent were obtained from all the study participants. The study conducted was a prospective parallel design randomized controlled clinical trial, and 18 participants were recruited from the outpatient clinic from July 2017 until December 2018. The inclusion criteria of the study was adult male and female patients of 20 to 40 years of age without any systemic diseases. Second, maxillary anterior necrotic mature teeth with single canals and having periapical lesions diagnosed as asymptomatic apical periodontitis and chronic apical abscess confirmed by preoperative digital radiographs. And third, negative response to sensibility testing, that is OLD test and EPT, were included. Exclusion criteria was patients with mobile teeth, stainless steel wires, brackets and implants, pacemakers, and those allergic to medication or antibiotics were excluded. Next, the participants were randomly divided based on the apical diameter size using ProTaper Next rotary instrumentation into two groups, the test group and the control group. Both the groups had 9 teeth. The test group, the apical diameter size was till X3, and in control group, the apical diameter size was X5. The allocation ratio between the test and the control group was 1:1. The participants, the radiographic specialist, and the statistician were blinded to the treatment group. Next, the patient medical and dental history was taken from all the patients. Clinical examination included the following: periodontal pocket depth, tenderness to percussion, and palpation to the apical area of the involved teeth, presence of a sinus tract, responses to sensibility tests. The radiographic examination included preoperative digital radiographs to confirm the presence of a periapical lesion. A preoperative MRI scan was performed using a 3 Tesla machine to measure the signal intensity of both the involved tooth and its contralateral at the middle and the apical third of the root canal. Next, all clinical procedures were performed by a single experienced and a calibrated investigator. In the first appointment, 2% lidocaine was given as local infiltration for the involved tooth. Rubber dam isolation and caries or defective restoration removal was done. Then access opening was performed using number 2 and 4 carbide rose head safe endozebras with water cooling system. Then canals were irrigated with 20 ml 1.5% sodium hypochlorite using side vented needles. Next, the working length was determined until the radiographic apex by an electronic apex locator. After the establishment of the glide path and confirming canal patency, rotary instrumentation of the canals was performed with pro taper neck spiles until size X3 in case of test group and X5 in case of control group. Then the canals were dried with paper points followed by ultra-cal XS calcium hydroxide delivery, which was 2 ml short of the radiographic apex. Then quality of the calcium hydroxide was assessed radiographically, and then the teeth were temporized using intermediate restorative material until the following appointment. In the second visit, if there were signs or symptoms of persistent infection, the disinfection protocol was repeated. If not, 3% mepivacaine without vasoconstrictor was administered, followed by rubber dam isolation. Next, calcium hydroxide was flushed out of the canals with 20 ml 1.5% sodium hypochlorite. Its complete removal was confirmed by magnification using an endodontic microscope. Later, the final rinse was done with 20 ml 17% EDTA, in which it was left in the canals for about 1 minute and then dried with paper points. Next, bleeding was induced into the canals by over-instrumentation by using a pre-curved K file of number 25 at 2 to 3 mm beyond the radiographic apex. The blood was left in the canals for a few minutes to allow clotting, and then biodentin was mixed and carefully placed over the blood clot. Radiographic assessment of the position and the quality of the cervical plug material was performed. Then coronal restoration using light cure resin modified glass ionoma restorative material as a base, and final composite resin restoration. Next, the high points were carefully checked to prevent traumatic occlusion. Post-operative clinical follow-up was done for both the groups after 1, 3, 6, 9, and 12 months. Treatment was considered successful in cases with a lack of pulpal pain, no sensitivity to percussion, and absence of any new developing signs or symptoms. A positive response to sensibility test indicated restoration of the tooth vitality when no sensation was felt at the maximum stimulus of 64, suggested that the tooth was non-vital. Post-operative radiographic follow-up included periapical digital radiograph for both groups after 6, 9, and 12 months to assess periapical healing, MRI signal intensity measurement of the regenerated pulp-like tissue after 3, 6, and 12 months of follow-up were performed. MRI data evaluation was done using the DICOM viewer software. First, the signal intensity of the regenerated pulp-like tissue was measured from the cross-sectional view by application of the middle and the apical third of the canal of the involved tooth and its normal contralateral tooth for both the groups. Second, the quantity of the regenerated tissue was visualized by the coronal reconstruction of the involved teeth from the 3D weighted images. An MRI interpretation was performed by an experienced calibrated radiology specialist. Statistical analysis. The calculated sample size per group was 6, and then it was increased to 9 to make up for 50% errors in processing. Therefore, the sample size used in the study was 18. Data were fed to the computer and analyzed using IBM SPSS software. Analysis of variance was used to compare more than 2 periods. The student t-test was used to compare the 2 studied groups. In addition, the Cochrane test was used to analyze the significance between the different periods. In the study, 18 necrotic mature maxillary anterior teeth were included, out of which 17 were maxillary central incisors and 1 was lateral incisor. And out of 18, 14 were diagnosed as asymptomatic apical periodontitis and 4 were diagnosed as chronic apical abscess. Patient ages in the study ranged from 20 to 34 years with a mean age of 25.5 years. And in the study, 13 teeth underwent trauma, and in 5 teeth, necrosis occurred because of defective restoration. Table 1 shows the demographic data of the participating patients. Table 2 shows the baseline MRI signal intensity measurement for both the involved necrotic and normal contralateral teeth at the middle third, while Table 3 shows the baseline MRI signal intensity measurement for both the involved necrotic and normal contralateral teeth at the apical third. Post-operative signal intensity in the test group and the control groups increased from its baseline values to reach the highest values at the third month follow-up interval, and these values then decreased and stabilized at 6 and 12 months to become approximate to the signal intensity recorded for the normal contralateral tooth. When comparing the MRI signal intensity of the baseline normal contralateral teeth and that of the involved teeth, after 12 months for both the test group and the control group at the middle and the apical third of the canal, there was no statistically significant difference between them. On clinical examination, no pain, no sensitivity to percussion or swelling in all 18 teeth throughout the follow-up period was observed, and periapical healing was observed in all the cases. Radiograph A shows periapical lesion related to tooth number 21. B shows the radiograph after 6 months. C shows the radiograph taken after 12 months of follow-up, showing complete healing of the periapical lesion. D shows baseline MRI signal intensity for both the involved necrotic and normal contralateral teeth at the middle third of the canal. And E shows the MRI signal intensity of the regenerative tissue after 12 months. While F shows the baseline MRI signal intensity for both the involved necrotic and normal contralateral teeth at the apical third of the canal. And the figure G shows MRI signal intensity of the regenerative tissue after 12 months. Radiograph H shows the baseline coronal reconstruction showing an empty pulse space at the middle third with hypointense necrotic tissue at the apical third of the canal related to tooth number 21 compared with the normal pulp tissue in the contralateral tooth number 11. I shows the radiograph taken after 12 months of follow-up showing regenerated tissue at the middle and the apical third of the tooth number 11. Now let's see the control group radiographs. Radiograph A shows the pre-operative radiograph with the periapical lesions related to tooth number 11. B shows the radiograph taken after 6 months, and C shows radiograph taken after 12 months of follow-up showing great improvement to the periapical lesion. While D shows the baseline MRI signal intensity for both the involved necrotic and normal contralateral teeth at the middle third of the canal. E shows the MRI scan of the regenerated tissue after 12 months, and F shows the MRI signal intensity for both the involved necrotic and normal contralateral teeth at the apical third of the canal, and C shows the signal intensity of the regenerated tissue after 12 months. H shows the baseline coronal reconstruction showing an empty pulp space related to tooth number 11 compared with the normal pulp tissue in contralateral tooth 21. I shows the 12-month follow-up showing regenerated tissue at the middle and the apical third of the canal of the tooth number 11. In the pool test, there was a gradual increase in the percentage of teeth regaining tooth sensibility throughout the study period to reach the highest level at 12 months. That is 77.8% in the test group and 88.9% in the control group. In the EPT result, in infected teeth, when the readings were registered between 30 and 39 with a tingling sensation, it was considered a positive response compared with the immediate positive response of the normal contralateral teeth with the readings from 0 to 3. The percentage of teeth regaining tooth sensibility using the EPT showed a gradual increase throughout the study periods to reach the highest level at 12 months, that is 66.7% in the test group and 88.9% in the control group. Now let's see the discussion. Maxillary teeth were selected in the study because single-rooted teeth with single canals was described by Vertesi, and it allows better standardization of the procedures conducted. In addition, most documented cases of regenerative procedure were performed successfully in maxillary anterior teeth by Kim et al. And Nigay et al. Patients between 20 to 40 years were taken because with the increase in the patient's age, certain physiological changes occur, which are thickening of the apical cementum, deviation of the apical foramina, which could affect the migration of mesenchymal stem cells into the canal by Morse et al. In the present study, sex was not considered as a factor because it was shown that it does not affect the gene expression of mesenchymal stem cell markers by Henry et al. In the test group, the selection of 0.3 mm apical diameter size was based on the fact that the average size of human cells ranges from 10 to 100 microns by Estefan et al. Loris et al. Found that 0.3 mm was sufficient to allow tissue ingrowth in an animal model. In addition, Abo et al. And Saud et al. Successfully treated mature maxillary anterior teeth with apical diameter sizes of 35 and 30 respectively. On the other hand, a systematic review by Fan et al. concluded that clinical success was achieved after a regenerative procedure in necrotic teeth with an apical diameter size from 0.5 to 1 mm. Moreover, other reported studies have successfully performed regenerative procedure with an apical diameter of 0.5 mm by Estefan et al. And Saud et al. Hence, 0.5 mm for the apical diameter was selected in this study to represent the control group. However, there have been no RCTs that have compared these two apical diameter for regenerative endodontic treatment of mature necrotic teeth in regard to healing outcomes. In the study, ProTaper Nextfire system is used because it gives a swaggering motion in the canal which activates the irrigating solution during instrumentation. It improves debris removal in a coronal direction, and there's less debris extrusion compared with manual and other rotary systems by Van et al. Pulp-dentin is used in the study because it promotes greater cell adherence and viability when compared with MTL by Graffiotti et al. And Laurent et al. It has good biocompatibility by Silva et al. Has good sealing ability by Ravichandran et al. Has bioactivity by Laurent et al. And it does not cause tooth discoloration by Keskin et al. Recently, Pulp-dentin has shown enhanced effects on the proliferation of stem cells together with its strong antibacterial properties by Fatty et al. Noticeable decrease in the size of the periapical lesion was seen in both the groups after 12 months. Regenerative endodontic procedure seems to promote the host wound healing process because of the immune defense mechanism of the regenerated tissues. By Saud et al. These results were in agreement with other studies that used regenerative procedure in the treatment of necrotic teeth with apical periodontitis in mature teeth by Nigay et al. In the present study, more than 83% of all the cases treated responded positively to cold test after 12 months, whereas 77% of all cases responded positively to the EPT. This is in agreement with Nigay et al., wherein 60% of the cases regained tooth sensibility at the end of 12 months, indicating the presence of vital tissues. In addition, Arslan et al. Reported a positive response to the EPT in half of the teeth treated with regenerative endodontic procedure. Furthermore, Lee et al. Confirmed nervous tissue regeneration by immunohistochemistry in the extracted immature permanent premolar tooth treated with regenerative procedure via flat clot. However, the results of the present study were inconsistent with the case series by Saud et al. And Nagas et al., who reported negative responses to sensibility tests after 26 months and 60 months of follow-up, respectively, in maturity. In the present study, the responses to POLD and EPT of the involved tooth were delayed compared with the normal contralateral teeth because of the presence of coronal plug material that makes it difficult for the vital pulp-like tissue response to be felt immediately. Next, the regenerated vital pulp-like tissue may have an immature innervation system, hence the response initially is delayed by Ricucci et al. This could also explain the fact that the response to sensibility testing increased with time in the current study, reflecting the development of a more organized nerve-like tissue by Nakashima et al. In addition, the use of pulp-dentin instead of MTA with its unique composition may also have allowed better conduction of the sensibility responses from the regenerated vital tissue by Akbulut et al. Still, there's a gap of knowledge regarding the exact mechanism of regaining tooth sensibility after regenerative endodontic procedure. There are various theories of nerve regeneration, which are nerve regeneration could be attributed to the blood clot being a rich source of endogenous growth factors, which are transforming growth factor beta, platelet-derived growth factor, vascular endothelial growth factor, and fibroblast growth factor that may aid in neurogenesis by Suleiman et al. The use of 17% EDTM causes release of dentin-derived growth factors that could promote neuronal growth and axonal regeneration. It also promotes cell proliferation, migration, and odontoblastic differentiation by Galler et al. The recruited stem cells in the root canal has the potential to differentiate into neuronal cells and induce axon guidance by Arthur et al. And Sai et al. Moreover, it has been shown that stem cells from the apical papilla may actually mediate cold responses by Iskander et al. It may be hypothesized that a similar mechanism may be effectuated by recruited stem cells after the induction of bleeding in maturity. Yet this area warrants for further investigation. Sensibility tests are subjective and does not assess the pulpal blood flow by Gopi Krishna. Therefore, MRI can be considered an objective, quantitative, and complementary assessment method to the sensibility test by Nakashima et al. Histologic examination is considered the gold standard assessment of soft tissue inside the root canal space, but it is destructive, traumatic, and requires tooth extraction by DiNardo et al. For these reasons, MRI was used in the present study to assess the vitality of regenerative tissue because it shows an excellent illustration of soft tissue without using ionizing radiation by DiNardo et al. In both the groups, MRI signal intensity of the treated teeth was found to be high after 3 months of regeneration and decreased significantly throughout follow-up periods to become equivalent to the normal contralateral teeth after 12 months. At 3 months, the regenerated tissue vasculature was partially restored because of angiogenesis after regenerative procedure, thus showing high signal intensity by Iohara et al. The significant decrease in the signal intensity to reach the normal contralateral teeth may be caused by development of more organized tissue in the canal, dentin deposition and mineralization, which may decrease vascularization in the canal, thus decreasing the signal intensity, which depends on the amount of water content in the soft tissue by Nakashima et al. And Ricucci et al. There are only 2 studies that assessed pulp-like tissue regeneration using MRI. The outcomes appear to be in agreement by Iohara et al. And Nakashima et al. Found high signal intensity after regeneration and decreased to reach normal after 180 days. In the present study, the signal intensity of the involved necrotic teeth at the baseline was hypointense, which is in accordance with Asaf et al., who assessed pulp vitality and detected pulp necrosis after traumatic dental injuries in children. This could be explained by the lack of perfusion of necrotic tissue, decreasing its water content, and thus giving a low signal intensity. However, in the present study, few necrotic teeth were hyperintense. This could be because of the fact that some inflammatory exudate from the periapical lesion may have filled in the canal space. Certain limitations of the study were MRI image quality may be reduced by metallic appliances and patient movements. The procedure is expensive, limited to hospital, and need qualified trained technicians. Other limitations were faced during regenerative procedures, such as difficulty in induction of blood in maturity with closed apexes, opacity of the biodentine that was similar to that of the normal dentine, making it challenging in its assessment by Asaf et al. And Cox et al. Hence, the conclusion of the study was vital pulp-like tissue could be successfully regenerated in mature teeth using regenerative procedure, which was not significantly affected by the size of the apical diameter. An MRI could successfully assess this tissue in a quantitative, non-invasive manner. This is an article by Arslan et al. On regenerative endodontic procedure in necrotic maturity with periapical radiolucency, in which he compared clinical and radiographic outcomes of regenerative endodontic procedure with that of conventional root canal treatment in necrotic maturity with periapical radiolucencies, and found that favorable clinical and radiographic outcomes were found in 92.3% and 80% in regenerative procedure and conventional root canal treatment groups respectively, and difference was not statistically significant. Half of the teeth treated with regenerative procedure responded to the electric pulse test. Hence, the study concluded that regenerative endodontic procedure have the potential to be used as a treatment option for mature teeth with large periapical radiolucency. This is another study by Ayohara et al. On assessment of pulp regeneration induced by stem cell therapy by MRI, which showed that pulp tissue was fully regenerated 90 days after cell transplantation, and signal intensity of the normal teeth was significantly higher than that of non-vital pulpectomized teeth and the controls of collagen transplanted teeth at 90 days. And stem cell transplanted teeth showed a gradual decrease in the signal intensity until 180 days, at which time the signal intensity was similar to that in the normal teeth and significantly higher than that in the teeth transplanted with collagen alone without the stem cells. Another study by Nakashima et al. On pulp regeneration by transplantation of dental pulp stem cells in pulpitis showed that electric pulp test of the pulp at 4 weeks demonstrated a robust positive response. Sorry. The signal intensity of the magnetic resonance imaging of the regenerative tissue in the root canal after 24 weeks was similar to that of the normal dental pulp in the untreated control. Finally, cone beam computed tomography demonstrated functional dentine formation in 3 of the 5 patients. Hence, I would like to conclude that the time is not far away when regenerative endodontic procedure will become a common treatment option to treat immature permanent teeth. Thank you.